and how to use it to make a better treatment decisions. Important disclaimer. Everything today is for educational purpose. All clinical decisions belong to you and your patient. Guidelines evolve, so always verify against the primary sources. With that said, let's go get into it. Here's a roadmap. We'll move through 12 key points, starting with the calcium score is, who to test, how to read the score, and then getting into the practical decision making around statins, aspirin, repeat testing, and special populations. We'll close with where AI is taking this field. Let's move fast. What is coronary artery calcium score? Calcium score is a non-contrast, non-stress, ECG-gated cardiac CT. About 10 minutes, no IV, no medication. It uses the Agatston method, plaque density in Hounsfield units multiplied by lesion area. Sum across all major coronary segments. Radiation is about 1 millisievert, same as the mammogram. The key validation data comes from MESA, over 6,800 symptomatic multi-ethnic adult follow-up for 10 years, and the Calcium Score Consortium with over 66,000 participants across 4 countries. This is one of the most robustly validated imaging biomarkers in cardiovascular medicine. The clinical use case is primary prevention, specifically adults at borderline or intermediate cardiovascular risk where the statin decision is generally uncertain. Patient selection, who should be tested? So who should you actually test? The 2018 ACC/AHA guidelines give this class 2A reasonable to use when the statin decision is uncertain. The sweet spot is adult age 40 to 75 with borderline risk. That's a 10-year cardiovascular score between 5 and 7.5%, or intermediate risk 7.5 to 20%, when either the patient or the clinician is hesitant about starting statin. Who should you not test? Anyone under 40, anyone with established cardiovascular disease. They already need statin, full stop. Anyone already on statin therapy and patients at low risk on the 5% where a negative test is expected and adds nothing. Remember, this test is a decision aid, not a screening tool for everyone. Calcium score categories and prognosis significance. 5 categories to know. A calcium score of 0 gives a 10-year event rate of 1.3 to 5.6 with only a 0.4% rate over 3 to 5 years. This is your statin deferral signal. Calcium score of 1 to 99. Event rate 3.8 to 8.3. Consider a statin, especially in patients over 55. A calcium score 100 to 299. Relative risk 4.3 times versus 0. This is a moderate to high intensity statin. A calcium score 300 to 999. A relative risk 7.2. A high intensity statin. Consider add-on therapy. And a calcium score over 1000. Relative risk nearly 11 times. This patient is a secondary prevention equivalent. Maximal statin plus Zetia or PCSK9 inhibitor, targeting LDL under 70. The numbers that changes everything clinically is 100. That's your threshold for mandatory statin therapy. 10-year cardiovascular event rate by calcium score. This chart puts the numbers in perspective. A calcium score of 0 gives you 0.4 event rate at 3 to 5 years. That's called warranty period, safe to defer therapy and reassess. A calcium score 100 to 299, relative risk 4.3 times compared to 0. A calcium score over 1000, a relative risk of 10.8. That's not a borderline patient anymore. When you show patient this chart, it moves conversations. Risk as a visual, not as an abstract probability, drives shared decision making. A statin decision making framework. Here is the clinical algorithm. Calcium score is 0. The first statin, the patient has diabetes. Calcium score is 0. The first statin unless the patient has diabetes, familial hypercholesterolemia, active smoking, or a strong family history of premature cardiovascular disease. Those are your 4 exceptions. A calcium score of 1 to 99. Statin is reasonable, especially over the age of 55. Consider a repeat calcium score in 5 years. If you defer, calcium score 100 to 299 or 75th percentile for age, sex, and race. Moderate or high intensity statin. A calcium score of 300 to 999. A high intensity statin. Add Zetia if LDL is still above 70. A calcium score over 1000. Maximum statin plus Zetia plus PCSK9 inhibitor if needed. We target LDL under 70 and at least 50% reduction from baseline. And across every single category, lifestyle modification is non-negotiable. Aspirin in primary prevention, guided by the calcium score. Aspirin is where calcium score really shines as a decision tool. The principle is simple. As the calcium score goes up, the net benefit of aspirin increases because the cardiovascular benefit begins to outweigh the bleeding risk. For calcium score 0 in primary prevention, aspirin is not recommended. The bleeding risk dominates. For calcium score 100 or higher, with a low bleeding risk and a 10-year cardiovascular risk of at least 5%, MESA data support a net clinical benefit. Don't reflexively start aspirin in primary prevention anymore. Let the calcium score guide you. Calcium score in shared decision making. Calcium score has a class 2A evidence specifically for shared decision making. This is where it really earns its clinical value. The ASCVD trial randomized patient to calcium score scanning versus no scanning and showed net reduction in blood pressure, LDL, and even waist circumference at 4 years. Why? Because patients who see their calcium score behave differently. A calcium score of 0 gives the hesitant patient a warranty period, a reason to commit to lifestyle without medication. A high calcium score gives the skeptical patient a reason to start a statin they've been avoiding. The NT to prevent one cardiovascular event over 10 years with the calcium score guiding high intensity statin therapy is 11 to 26. That is excellent for a primary prevention strategy. Repeat calcium score testing. When and when not to. When you should repeat the calcium score. Only if untreated patient. A calcium score 0 with ongoing risk factors after 3 to 5 years, or a calcium score 1 to 99 after 5 years. If you defer therapy. Critical rule, and I want you to remember this: do not order a repeat calcium score in any patient already on a statin therapy. Statins stabilize soft plaques and accelerate its calcification. The scores goes up. Not because atherosclerosis is worsening, but because statins are working. You cannot use calcium score progression to measure statin adherence or efficacy. is one of the most common and consequential misapplications of these tests. Limitations of calcium scoring. Calcium score is a powerful tool with real limitation. First, it cannot detect non-calcified soft plaques. Up to 14% of patients with flow-limiting stenosis have a calcium score of 0. Second, radiation, 1 millisievert per scan. Low but relative when you are considering repeat imaging in a healthy population. Third, in generally lower risk patients under 5% cardiovascular risk score, incorrect reclassification outnumbers correct reclassification by more than 5-fold. Don't test low risk patients. Fourth, incidental non-cardiac findings occur in up to 58% of scans. Pulmonary nodules, aortic aneurysm, generating downstream anxiety and cost. And fifth, insurance coverage is inconsistent with out-of-pocket costs from $75 to $400, which widens existing healthcare disparities. AI opportunity calcium score detection. This is where the field is heading. About 19 million non-cardiac chest CT are performed annually in the US alone. Every one of them passes over the coronary arteries, but currently only 31 to 44% of incidental calcium is even reported by radiologists. Peng et al. In JACS 2023 showed that the calcium score detected on routine ungated CT scans carries a hazard ratio of 1.51 for all-cause death and 1.57 for composite death, MI, or stroke. Identical prognosis, weight to gated scan. And McKinney et al. In 2025 showed that a deep learning AI model achieved a kappa of 0.959 against expert radiologist consensus. Population scale cardiovascular prevention. No additional radiation, no additional cost. Through scans we are already doing. This is not a distant future. Special populations. The nuances of calcium score interpretation. A few high-yield population perils. Diabetes. The statins are already indicated in most diabetic regardless of the calcium score. Don't use calcium score to justify withholding therapy. Women are frequently undertreated. MESA shows the same proportional risk increase in women as in men. Calcium score helps close the gap. Young adults age 40 to 50. Calcium score 0 is common and strongly negative predictive, but any calcium in a young patient carries serious weight. Cardiac data show a hazard ratio of 5.8 for coronary events in young adults, with a calcium score just 20 to 99 versus 0. CKD calcification is accelerated by non-atherosclerotic mechanisms. Interpret with caution. Elderly over 50. Over 90% have a calcium score above 0, so discriminative value is minimal. High-intensity statin is usually already indicated on age and risk alone. Beyond the statins, additional therapies guided by calcium score. Calcium score guides more than just statin. For a calcium score 300 or higher, the risk is equivalent to established cardiovascular disease. Treated that way. Add Zetia if LDL stays above 70 on a statin. For calcium score 1000 or higher, the NLA gives a class 1 recommendation for maximum statin plus add-on therapy. Targeting LDL under 70 with at least 50% reduction. Aspirin for calcium score 100 or above with a low bleeding risk as we discussed. And when calcium score hits 400, about half of patients have significant obstructive disease. If symptomatic, move to functional stress testing or coronary CT angiogram. Lifestyle modification is the baseline for everyone, always. Treatment recommendation by calcium score summary table. Here's your quick reference table. Calcium score, statin, aspirin, add-on therapy, and further testing by tiers. You should print this, post in your clinic. The 5-row summary map directly to the clinical algorithm, and the guideline reference are all listed. Clinical practice pearls. 6 pearls to take home. 1. Order selectively. Borderline to intermediate risk adults with a genuine statin uncertainty. 2. Calcium score 0 is a powerful negative predictor with a 0.4 event rate at 3 to 5 years. But it doesn't exclude soft plaque, so lifestyle and reassessment still apply. 3. A calcium score 100 or above triggers mandatory statin therapy. 4. Aspirin tracks with calcium score not recommended for 0, beneficial for 100 or above with a low bleeding risk. 5. Never retest on statin therapy. You will always see the score to go up, and it means nothing about disease progression. 6. AI is democratizing this test at population scale through opportunistic detection on routine CT already being performed every day. These are the reference, all primary reference are here. ACC, AHA 2018 and 19, NLA 2021, MESA, Eisner, Calcium Score Consortium, and the 2025 AHA AI statement. Thank you, everyone.